Welcome to our webinar series for professionals.
Welcome everyone. I'm Anne-Catherine, co-founder of Nordic Laboratories and DNA Life, and it is an absolute pleasure that you've logged in and wanted to join us on the topic about perimenopausal treatment strategies and inspiration on how to interpret Dutch tests and Dutch reports and how to help your clients the best way. So we actually, for those of you who may get even more hungrier after today and who has nothing to do this weekend, then we are in Amsterdam Saturday and Sunday educating in just hormones both days with we have Diana, I can't see if she's online here, and Lenoy, Belgium doctor, who is going to help us and who does the education. So I'm really excited. I'm going to fly down there tomorrow. So just to let you know a few of our plans. We also have an event in London in November on the weekend where it's the 15th of November. That's going to be all sorts of topics. So yeah, but we are excited about that, and we'll obviously send out details and information around it in the hope that you will come and meet us in person. So, but remember, this event or this webinar we are recording as we normally do, and the recording will be shared with you, and also the slides will be shared with you. And I've promised to take a little note if there's any supplements that are especially interesting, then I can maybe link to them and put them in the email when we send out the recording to you all. So I'm happy with there's a lot of good people here on live. So it's going to be nice to have the interaction on the question and answers, and remember to say hello to each other and let us know where you're from. And I'll take notes if there's questions, and then we'll do some Q&A at the end. So Kelly is here with us from Precision Analytics. She's a naturopathic doctor. Yeah, she's gonna inspire us with her and be with us for the next hour or so. So I'll pass on the screen to you, and then yeah, I'll mute myself, but I'm here to help and service and answer questions and yeah, make things easy.
Sounds good. Thanks for having me. I'm excited to be here. I'm excited to be talking about perimenopause. It can be a complicated time in a woman's life, right? Let me share my screen. Okay, can you all see? Yep, it's coming through. Looks good. Okay. All right, so today we're going to be talking about how to improve perimenopausal treatment protocols using Dutch testing. And we're going to get into the physiology of perimenopause. We're going to even talk about serum testing. And then when it comes to treatment options, we're going to talk a lot about lifestyle, supplements, and even hormone therapy. So we get a lot of questions during consults. Oh, like, can I add on progesterone or can I add on estrogen? She's not fully menopausal yet. So we're going to answer those questions today. So yeah, I am Kelly Ruef. I'm a clinical educator for Precision Analytical, makers of the Dutch test. And this is my work email, drruef@dutchtest.com. If you ever have any questions, feel free to email me. I love to interact with people and chat and, talk about hormones in general. These are the learning objectives. So basically we want to understand like the physiology, the symptoms in perimenopause, what lab findings, both serum and urine, how to distinguish that early perimenopause phase from the late perimenopause phase. And in the literature, they call it the early menopausal transition or the early menopausal transitional stage and the late menopausal transitional stage. So even though it says menopausal, we're actually talking about perimenopause, but I'll probably just say early perimenopause and late perimenopause to keep it pretty simple. We want to recognize that the treatments we decide to use are going to be different, whether she's in the early stage or the late stage for most women. And understand how both we can use those symptoms, we can use our lab findings to help guide our treatment plans. Okay, so what is perimenopause? If you compare it to menopause, perimenopause happens about 2 to 8 years before menopause when we start getting those hormonal changes. Menopause is more so like once you've hit those 12 months without a period, you can be officially diagnosed as menopausal. And menopause happens for most women around, usually around 45 to 55, but the range is wider. The range is 40 to 58. But if you go into menopause at 40, that's going to be considered early menopause. Now, if you're 40, 41, 42, 43, 44, and you go into menopause, that's considered early menopause. So here's a nice little diagram or image. So we can see here our reproductive phase, premenopause, when women are fertile, some of them are having babies. And then we reach that early menopausal transition. So this is early perimenopause. A lot of times it happens in women, in their 40s. And then we get to that late transition. And the late transition, a lot of times that precedes menopause. So a lot of times we have lower hormones in that late transition. And then our final menstrual period, we don't know it yet, but if that's our final menstrual period, like that's menopause. We've hit menopause, but we don't know we hit menopause until 12 months later when we look at the calendar and we're like, oh, it's been 12 months. I haven't had a period since last June. Guess I'm considered post-menopause now. So then you get post-menopause. And people use that term post-menopause and menopause interchangeably. All right, so the physiology of perimenopause. And in order to understand the physiology of perimenopause, we really have to understand the physiology of pre-menopause or like younger cycling women, what they're going through. So a younger cycling woman who's fertile, during that reproductive stage, during her cycle, her monthly cycle, her brain and her ovaries have excellent communication. So remember, we all know that the brain throughout the menstrual or throughout the cycle, the brain is constantly talking to the ovaries and checking in with the ovaries and telling the ovaries to make, to grow follicles or to ovulate or to make progesterone for the corpus luteum. So we've got the hypothalamus in the brain releasing gonadotropin releasing hormone or GnRH. And that makes its way to the pituitary, which is also in the brain. And then the pituitary releases LH and FSH. And LH is luteinizing hormone. That's usually what causes ovulation and tells the corpus luteum to make progesterone. And then we have FSH, follicle stimulating hormone, which tells the ovaries to make develop a follicle. The ovaries are really interesting. Back when I was in school, I didn't realize, I don't think I was ever taught that the ovaries can make their own, I think these are glycoproteins, inhibin A and inhibin B. So the follicles are making inhibin A and inhibin B, and inhibin A and inhibin B mostly suppress FSH. It's probably so that the ovaries don't develop too many follicles, right? So we don't have like a litter every time we get pregnant. But the ovaries, they also release estrogen and progesterone, and those can have a negative feedback, usually a negative feedback on the brain. So this is what excellent communication looks like. We've all seen a graph of the menstrual cycle, but usually the cycles are regular. They're every 28 days or they're every 35 days, or sometimes they differ a little bit, but usually they're pretty regular. And remember, a normal cycle is usually about 25 to 35 days in length, but the range is from, I think, 21 to 35 for women, but if you're a teenager, it's like 21 to 45. They consider that normal. In a normal, regular cycle, ovulation occurs about midway through the cycle or about 2 weeks before the menses, and estrogen and progesterone are pretty balanced. We have enough progesterone around to inhibit all those or kind of keep estrogen in line, balance out all those proliferative effects of estrogen so we don't get heavy bleeding or grow fibroids or grow polyps, etc. So here's an example. This is a Dutch test, a Dutch cycle mapping example of a woman with really great HPO access communication. She's 39, she's cycling regularly. You can see estradiol and estrone up top, and then the progesterone metabolites down below. So early in the cycle, the brain releases that FSH, and the FSH goes to the follicles and tells the follicles to start developing a follicle, right? And then those follicles make estrogen. And eventually one follicle is chosen to be the dominant follicle. And as that follicle gets bigger and bigger, it makes more and more estrogen until estrogen surges. And when the estrogen surges, the brain releases LH, luteinizing hormone, and triggers ovulation. And then LH also tells the corpus luteum to make progesterone. So remember, when you ovulate, that egg comes out of the follicle, and then the follicle turns into the corpus luteum. And the corpus luteum keeps the party going. It makes progesterone. So we can tell she ovulated. Like, look, right after her estrogen ovulatory surge, her progesterone comes up. So that's her corpus luteum making progesterone. And of course, progesterone is thermogenic. It increases the basal body temperature. And it's also very normal for estrogen to come back up too in the luteal phase. So during perimenopause, that communication between the brain and the ovary starts to break down. And, why is that? Well, partially as we get older, we get less and less follicles. We get smaller follicles. We get more abnormal follicles. And the less follicles, the less eggs we have, it leads to less feedback from the ovaries. And the brain doesn't like that. I don't know if the brain likes it or not, but I like to think the brain doesn't like it, and the brain's like, why aren't you talking to me? So the brain starts, the brain has to work on its relationship skills. It starts like screaming at the ovaries, like, hey, ovaries, you better listen to me. I want you to ovulate. I want you to make that egg or develop that follicle. So LH and FSH tend to go up in perimenopause when the brain starts screaming at the ovaries, like, hey, ovaries, don't retire yet. I still want you to be in this relationship, So a lot of times this dysfunctional communication leads in the early perimenopause stage, it leads to high estrogen. A lot of times you'll see these like huge estrogen surges, irregular cycles, and low progesterone. So you can see here, like this is a reproductive ovary in a younger cycling premenopausal woman. She's got a lot of follicles. The green ones are normal, the black ones are abnormal, minimal abnormal follicles. She's got one dominant one here. And then early perimenopause, you can see more abnormal follicles, less follicles in general, less eggs. And then late perimenopause, we might still have a few normal follicles, but we're starting to see a lot less and more abnormal ones. Anything else? Yeah, and progesterone can decline even if ovulation occurs. As we get closer to menopause, you'll oftentimes see that the corpus luteum's production of progesterone goes down over time. All right, so here's a nice little graph. We can see that when we're children, we don't have much estradiol, which is pink, or progesterone, which is blue. But then we hit our teenage years, we go through menarche, we get our period for the first time, and our estrogen and our progesterone levels go way up, relative to a baby or a child. And then they're pretty stable. Hopefully we're cycling regularly. Hopefully we're ovulating every month. And then we hit perimenopause. And this is when I say women get on that estrogen roller coaster, because sometimes we see these huge surges of estrogen in our perimenopausal population. On the Dutch test, like I have seen women's estrogen surge above the upper limit of the ovulatory range for like 3 weeks straight and not ovulate. That's a lot of estrogen. So you got to wonder, like, oh, okay, no wonder she's bleeding heavily. No wonder she's spotting. No wonder she's feeling like she's crazy and she's has emotional lability and she's crying and, has breast tenderness. It's because the hormones are dysregulating. But then we get towards menopause and they regulate again, but I mean, not regulate, but they just end up being low, both low, back like when we were children. This is another image that I really like. It shows the same thing, but it kind of shows it a little more in detail. You can see we got more regular cycles and then they become irregular. We have our last period and then just low estrogen and progesterone. So with the symptoms, early menopausal transition and late menopausal transition, the symptoms are usually different. Not always. You know, some women enter perimenopause and they just have low estrogen and low progesterone. Some women never really go through this estrogen roller coaster, as much as other women. So overall, in early perimenopause, women are more likely to have that estrogen dominant type symptoms, heavy menses, breast tenderness, shorter cycles. Whereas in late perimenopause, when they get closer to hitting menopause, they're more likely to have those estrogen and progesterone deficiency symptoms like hot flashes, vaginal dryness, pain with sex, depression, brain fog, insomnia, and very, very long menstrual cycle intervals. Like they might not bleed for 2 or 3 or 4 or 5 or 6 months. In early perimenopause, one kind of way you can tell that you're entering perimenopause is your cycles aren't regular anymore. They're more variable, right? So you can get this more persistent 7 or more day difference in the length of consecutive cycles. So you might have a 20-day cycle, then a 32-day cycle, then a 37-day cycle, then a 19-day cycle. Whereas when you get in the later stage, you have intervals of amenorrhea for longer than 60 days. So you might go 2 months without a cycle, and then a month without a cycle, and then 3 months without a cycle. In early perimenopause, with your mood, you're more likely to be anxious and irritable, tearful, have more of that emotional lability. Whereas in the later stage, you tend to have more just lower mood, depression. And this is not true for every woman. This is just what we typically see. In the early transition, we tend to see more of those estrogen dominant symptoms like heavy periods, breast tenderness. But as we get closer to menopause, that occurs less frequently. It can still occur. Like sometimes we haven't had a period for 3 months, but then all of a sudden the ovaries decide to kick back in and you might have a huge estrogen surge and you might actually get like a heavy period, even though you haven't gotten a period in 3 months. And these symptoms here, they get worse as we get closer to menopause, typically. So the brain fog, not being able to sleep, musculoskeletal pain and stiffness, hot flashes, vaginal dryness, you tend to see those a lot towards the later stage. And we like to keep in mind that perimenopausal symptoms, they're not always related just to the hormones. They can also be related to aging, lifestyle, diet, disease processes. So like this is an extreme example, but we wanted to use an extreme example here. Sometimes heavy menses is the result of, undiagnosed endometrial cancer. So we always want to do our workup, our proper workup. Interesting to know, like in perimenopause, that risk of endometrial hyperplasia and cancer goes up, which makes sense because usually we're having more estrogen and less progesterone. Okay, so here's some underlying health conditions that can also contribute to perimenopausal symptoms: inflammation, insulin resistance, stress, poor underlying cardiovascular health, sedentary lifestyle. So we want to be looking at the whole person and working on everything together. Okay, lab testing. So a lot of medical associations don't recommend hormone lab testing in perimenopause because they say it's challenging. One cycle doesn't look like the next cycle, and there's no lab test to predict like how long perimenopause is going to last when you're going to hit menopause. But, you know, testing a typical perimenopausal presentation might be reassuring to the patient. Sometimes we have people do the cycle mappings and, they see their estrogen surging for 3 weeks and no ovulation. And they say, okay, like this makes sense with how I'm feeling. I feel like I've been validated. And now we know that we can really work on trying to lower that estrogen or, balance it with progesterone. We might add on progesterone therapy. But some people don't test during perimenopause and they might just have patients really document their symptoms on a day-to-day basis and look for trends. Like, okay, well, it seems like you're having a lot of high estrogen symptoms for those 2 weeks. But then you go months with low estrogen symptoms and hot flashes, and you can kind of understand what's going on just from the symptoms. But also, testing can help a provider decide like what type of hormone therapy they might want to add and the dose, what starting dose they want to use. And I think this is especially helpful for the androgens like testosterone and DHEA, because those can vary greatly in women. Like some women have beautiful looking androgens, but some women have like very low, bottomed out androgens. So with lab testing, a lot of this is talking about serum testing, but AFC, antral follicle count, this is an ultrasound. This is actually counting the follicles. And the AFC goes down with age because the follicles, the egg number goes down. AMH, anti-Müllerian hormone, this, a lot of times we're testing this for fertility, to look at ovarian reserve. This also declines as we get closer to menopause. The inhibin A and inhibin B, remember these guys that the follicles are secreting? Well, that goes down over time because we have less follicles. And then on cycle day 1 through 5, a lot of people will do cycle day 2 through 3. But on 1 through 5, if we look at FSH and estradiol, we want to measure both of them together because, for example, in early perimenopause, and I think this is a cool concept to grasp. So in early perimenopause, when the follicles may be still sensitive to FSH, remember the brain screams at the ovaries and increases FSH. So some cycles have follicles that are more sensitive or might have like a normal sensitivity to FSH. And when the brain screams at those follicles to produce an egg, the FSH levels can cause those follicles to like over respond. Because remember, the brain screaming, the FSH is really high. Sometimes those follicles actually listen and they overproduce estrogen. And high estrogen can suppress FSH. So what I'm getting at is as we get closer to menopause, FSH goes up and up and up. In a normal cycle, it might come back at like, in like a younger cycling woman, FSH might come back at like 5 or 6. But then as they get into early perimenopause, it might come back at like 10 or 12. And as we get close to menopause, it might come back at 90 or 100. But in early perimenopause, when you do have some cycles, when those follicles are still sensitive, they might overproduce estrogen and kind of drop that FSH back into range. So you want to test them together. But then as you know, as you get closer to menopause, the follicles become less sensitive to FSH. You're more likely to see that high FSH and the low estrogen. This is a nice table that you can print out. It basically just tells you how estrogen, progesterone, FSH, inhibin B, and AMH change as you get closer to menopause. And of course, inhibin B, AMH go down, FSH goes up, progesterone can go down over time, and then estrogen can go up initially, but then usually it's pretty low when you hit menopause. So the Dutch cycle mapping report, I know I introduced this earlier, but it's interesting because it does show the estrogen and progesterone during one collection period or one cycle. And sometimes that's helpful when women don't know when they're ovulating in perimenopause, or maybe they're not ovulating. And so they don't know how to time a serum, a 1-day serum test, or a 1-day Dutch complete or Dutch plus urine test. So it can be helpful to see like overall estrogen exposure during that month. It can be helpful to tell like, did they ovulate? To catch that ovulation. And of course, with Dutch, we're using liquid chromatography mass spectrometry, LCMS. This is the very ultra sensitive testing. And that's important in general in perimenopause and menopause because in the serum or the urine, if you use immunoassay to measure estradiol, it's not going to be as accurate because at least when estradiol is low, immunoassays are less accurate. So you want to order the LCMS in the serum or use the LCMS Dutch test, especially for like low estrogen or to measure testosterone in women. And here are some interesting reference ranges that you can print out. All right, so the perimenopause workflow, what do we do? First, we're always going to do a thorough history intake. Ask about, past history of breast cancer, cardiovascular disease, etc. And as far as lab testing, there's two options. I mean, there's a lot of options, but there's two options that we think about. One option is to look at hormones in that early follicular, cycle days 1 through 5, and then mid-luteal, which is about a week before they get their period. So if we look at the blood, we might want to look at FSH and estradiol on like cycle day 2. And you can add on AMH and inhibin B, can give you a little more information about where they're at in that menopausal transition. But these tests can be more expensive. I think AMH over here in the States is about $50 and inhibin B is about $150. And then mid-luteal, we can look at estrogen and progesterone. Look at their levels, look at the balance between the two. Or sometimes people will kind of do like a blood draw in the early follicular, around cycle day 2 to look at FSH and estradiol because the Dutch test doesn't look at a FSH. You have to do it in the serum. But then they might pair it with a Dutch cycle mapping, paired with a Dutch complete or a Dutch plus. And this can give you information about the hormones during the entire cycle. So you'll be able to pinpoint that luteal, mid-luteal spot, what do hormones look like in that mid-luteal point. And this is the Dutch cycle mapping. You can see estrogen and progesterone, but the Dutch cycle mapping doesn't give you information about like how that estrogen is being metabolized in phase 1 and phase 2, or how the progesterone is being metabolized. It doesn't tell you about androgens or cortisol or the organic acid. So if you want that also, you have to pair it with a Dutch complete or a Dutch plus. And remember, if you do a serum testing, you really got to try to time it to that mid-luteal phase Because let's say we timed it a little late. Let's say she got her period like 3 days later from after doing the serum draw. We might think that she's got lower hormones or lower progesterone than she actually does because we timed it late. So ideally, if we get that blood test done, we want them to get their period about 5 to 9 days later. So if you test in the mid-luteal phase, you'll get your period about 5 to 9 days later. And at the first visit, a lot of times people will provide appropriate lifestyle approaches, and they might add on hormone therapy at that time. At follow-up, of course, we're going to review their symptoms, see if they've improved, if they've changed at all, and then review lab workup and consider additional treatments, including hormone therapy. So basically, at the initial visit or the second visit, when you're looking at all the labs, sometimes people will add on hormone therapy at that time. A lot of times we're doing a lot of, dietary, lifestyle, supplement changes too. Okay, so perimenopause treatments, hormone therapy. When we get to hormone therapy, you can use hormone therapy in perimenopause. That's the good news. And a lot of times we're using bioidentical estradiol. There's other forms out there. There's the CEEs, the conjugated equine estrogens. There's the synthetic estrogens, ethinyl estradiol that you see in birth control. But for hormone therapy and like the functional medicine space, a lot of times we're using that bioidentical estradiol, which just means the chemical structure is bioidentical to the estradiol that our own body makes. And transdermal estradiol is a pretty standard route of administration because it's pretty low risk, it's easy to access, and it's effective. Oral estradiol, it's probably the most common prescription. In conventional medicine, you'll see it a lot. But we know that it can increase cardiovascular disease risk. So it might not be the right ROA or route of administration for all people. People who already have cardiovascular disease or people who are at increased risk of cardiovascular disease, like smokers, might not want to give them oral estradiol. But what we found when we did our intro to, what does it call it? Intro to menopausal HRT Dutch course, we found that oral estradiol is actually pretty safe for like younger women just entering menopause who are pretty healthy. And sometimes it has a little bit added benefit where it can really help with that lipid profile, maybe more so than transdermal. But I think of oral estradiol, if I ever used it, it would be in like a woman in her late 40s, early 50s, who's really healthy, no cardiovascular disease. And then, of course, as she gets older, I would transition her to transdermal because it's safer. And then vaginal estradiol can be used in low doses for like localized effects for vaginal atrophy, vaginal dryness. And for that, you can start that in perimenopausal women and menopausal women. It's really safe. If you're using a low enough dose, you could even use it in a woman in her, 80s, 90s. So we want to start at the lowest dose and increase slowly to minimize the risks and increase the benefits. And for progesterone, we're usually also using bioidentical progesterone. And oral or vaginal, these two forms have been shown in the research to protect the uterus against hyperplasia and cancer. So that's why we focus on these two forms. Also, they tend, bioidentical progesterone tends to be safer than these synthetic progestins like MPA. MPA carries that increased breast cancer risk, and it's more thrombogenic, so it's going to be worse for the cardiovascular system. Oral micronized progesterone, OMP, we call it OMP. It's the only like FDA approved bioidentical progesterone. But if women don't tolerate it, sometimes it makes women tired or dizzy or moody, or they get breast tenderness or they get headaches. Then there's a lot of research on vaginal micronized progesterone to protect their uterus, like if they're also taking estrogen at the same time. At this time, if you look at the research, transdermal progesterone, the research says transdermal progesterone, if the woman is also on estrogen therapy, it's not going to protect her uterus from hyperplasia and cancer. But some people still use it. And I say, if you still use it, you could do ultrasounds and look at the endometrial stripe, the endometrial thickness, and just keep an eye on it to make sure it's not getting too thick. So hormone therapy, estrogen, it's FDA approved for just a few things. For basically hot flashes, prevention of osteoporosis, vaginal atrophy, dryness, and then women who go into premature hypoestrogenism, like women with premature ovarian insufficiency or iatrogenic menopause. Maybe they get their ovaries removed. But estrogen, we know, can do has a lot of other benefits, right? Like can protect the cardiovascular system, help with sleep, dementia in some populations. The dementia is really like if you start it early, you got to start it early to really improve brain health. And I mean early as in like not in our 70s, but more like when we are going into menopause. Weight management, mood, skin, joint health, and overall quality of life. OMP, the oral progesterone, it's FDA approved for, that prevention of endometrial hyperplasia. But it can also help with bone mineral density, with mood, hot flashes in some women, and it can have some potential brain protective effects. One interesting thing, though, they found that if women cycled progesterone, so if you had a postmenopausal woman and you gave her estrogen every day and you cycled progesterone for like 12 to 14 days out of the month, you would get more improvements with brain, more beneficial effects on the brain than if you gave both every day. And they were saying that progesterone to some degree blocks estrogen's effects in the body. So if you take progesterone away for half of the month, estrogen can fully like infiltrate that brain and have its positive effects. Just a fun fact. So contraindications, of course, we always want to look at the contraindications before we start hormone therapy. If you want to learn more about hormone therapy, I really do, what's that word I'm looking for? Recommend. I do recommend the intro to HRT course, the Dutch course, because we go into all the risks and the benefits and the research, and it's very, I think it's like a 5 or 6 hour course if you really want to dive in. But a lot of the estrogen therapy contraindications are related to cardiovascular health or prior breast cancer. When you look at like a OMP or oral progesterone label, it has all these contraindications on it. A lot of these are from data and research on progestins, synthetic progestins, which we know can increase risk for breast cancer, and they're more thrombogenic. So just keep that in mind. So, and the contraindications, they're based on long-term use in postmenopausal patients. Of course, we want to review it even in our perimenopausal patients, but usually our perimenopausal women are, they're younger than our postmenopausal patients. They're a little healthier. Oh, and here's our introduction to HRT course. So Carrie Jones and Jacqueline Smeaton teach that course. And of course, not all emerging symptoms are directly related to hormone changes. So there's a lot of lifestyle things we can do too with our perimenopausal patients, like quit smoking, weight loss, encourage weight loss, reduce or eliminate alcohol consumption. A lot of women in perimenopause will notice they can't tolerate alcohol like they used to. right? Which is a bummer because usually during that time is when we want to drink more. Because, we're going through a lot of changes and we have aging parents and we have children to take care of and we're in our career. And it's like, can I just have a drink and not pay for it later? We want to really optimize hydration, get our electrolytes during this time, get movement, yoga, weightlifting, or even mobility. What I've been doing, what I really love lately is mobility exercises. If you go to YouTube and you type in like mobility workout, you'll find some. Um, Mindfulness-based stress management, the Mediterranean diet. We put this here because there's just a lot of research on it. And then sometimes non-hormonal medications, SSRIs, progestin IUDs. And actually, if you put a woman on estrogen and you don't want to put her on bioidentical progesterone for some reason, maybe she doesn't tolerate it, you can do a progestin IUD to protect her uterus from hyperplasia and cancer risk. So the British Menopause Society says, yeah, you can put a progestin IUD in there. Okay, so when do you start treatment? A lot of conventional guidelines, they wait until they hit menopause, like wait until the diagnosis of menopause. But a lot of women are suffering for like 2 to 8 years before they hit menopause. So why are we depriving them of hormones during that time? So you can add on hormones when appropriate. When we start hormones, it really depends on their symptoms. We're going to stage them. Do you think you're in early perimenopause or late perimenopause? And in early perimenopause, when we're on this estrogen roller coaster, a lot of times just progesterone therapy can be helpful. Whereas in late perimenopause, when both of our hormones decline, that's when we think about estrogen and progesterone. So here's some considerations for when you might use progesterone, estrogen, or DHEA. And we don't talk about DHEA during this presentation, but yeah, DHEA can be really helpful for perimenopausal women. Just keep in mind that DHEA can convert to estrogen. So depending on the dose of DHEA and how long you're using it, it can increase estrogen levels. But basically, when we think about adding on progesterone, this is when women have a lot of estrogen dominant symptoms, heavy bleeding, they might be anxious. Progesterone, the alpha progesterone metabolites modulate GABA receptors. They have that really calming effect. So progesterone can help anxiety, insomnia, irritability, agitation. And then estrogen, we want to think about adding that on when women have more of those consistent low estrogen symptoms. So the early menopause transition, like we said, we get that persistent 7-day difference in the length of consecutive cycles. They're more likely to have the estrogen dominant symptoms and more of that anxiety, irritability, emotional lability. With the lab findings, the FSH is still pretty variable. Like some cycles are normal and their FSH might be 5, but then another cycle might be a little off and their FSH might be 12. The AMH tends to be low. As we get older, it goes down. Same with inhibin B, it goes down. And the antral follicle count, the number of follicles goes down. And then estradiol, it's that roller coaster. Sometimes it's high, sometimes it's low. One cycle might not look like the next. Progesterone, if they ovulate, could be normal. If they ovulate, it might be a little lower than it used to be. But anovulation does start to occur more frequently. So they might have that estrogen surge, but no ovulation. And here's a example. So this woman, she's 44 and she's got those irregular cycles, 20 days, 28 days, 23 days. She's got low libido, anxiety. She's like, gosh, my anxiety is getting worse than it used to be. I can't sleep. I'm tired. And her FSH was 11. So it was a little elevated on cycle day 2 or 3. So we can see that she's getting that estrogen surge a little bit earlier than you would typically see in a woman with a 28-day cycle. And she's got lower progesterone production. But did you notice she didn't have heavy bleeding and she didn't have breast tenderness? And it might be because like her estrogen didn't surge super high like it can during early perimenopause. Like her estrogen levels are pretty normal, but her progesterone is a little bit on the lower side. Let's look at this one. This is more of a picture that I think with early perimenopause. Like this woman, she's 47. She's got those irregular cycles. She's in early perimenopause. She's got tender breasts. Her hair is thinning and she's gaining weight. And look at this. Her estrogen is surging above the upper end of the ovulatory range. And it's surging for, I don't know, I guess it's did like 35 minus 20 or so, maybe 15 days, but then no ovulation. Look how flatline her progesterone is. So she's getting exposed to all this estrogen, and estrogen is proliferative. It causes tissue growth, and no progesterone to balance it. So again, early perimenopause, progesterone therapy might be helpful. So with her, we might add on progesterone therapy. We might cycle progesterone therapy. And oral micronized progesterone, it has a couple things it does, which was just interesting. It stabilizes that uterine tissue growth, so it can help with heavy bleeding. And it reduces estrogen receptors and receptor functionality. Remember, we were just talking about this with dementia, with brain health. And when you use progesterone and estrogen every single day together, that progesterone can reduce estrogen receptors in the brain, limiting the effects of the estrogen in the brain. I thought this one was interesting. It provides feedback to the HPO axis to suppress FSH. So remember, as we get older, FSH goes up. If you take progesterone, it'll suppress that FSH back down. So just giving progesterone might help lower ovarian estrogen surges during early perimenopause. So here's some positive evidence for only using oral micronized progesterone in perimenopause. So we've got these early perimenopause symptoms: heavy bleeding, endometrial hyperplasia, abnormal uterine bleeding due to ovulatory disorders, aka early perimenopause, cyclic nostalgia, breast tenderness, hot flashes, insomnia. So there's some research showing that oral micronized progesterone on its own can improve these. But progesterone does have some side effects. Sometimes if women push through it, if they might have these side effects for the first 2 weeks and then they'll go away. But sometimes you do have to change the dose, change the route, or maybe go with like a progestin IUD. With oral micronized progesterone for dosing, for early perimenopause, the range is about 100 to 400 milligrams at night. Remember, it kind of makes you drowsy, so women take it before bed. When you hit menopause, the dose range is about 100 to 200, just lower. And remember, if we use cyclical progesterone, so if we have women only take progesterone for half the month, they can sometimes have a withdrawal bleed. So in like your menopausal patients who are like, yay, I don't have a period anymore. If you start doing the cyclical progesterone, maybe to improve brain health, like improve the estrogen therapy's effects on the brain, they might have a withdrawal bleed and they might not like it. Okay. And then we know changes in progesterone, changes with ovulation can be naturally supported with these things: stress reduction, more GABA calming support. So here for supplements, we think more like GABA, L-theanine, passion flower, valerian. Sleep hygiene. Sleep hygiene becomes so important in perimenopause. Low glycemic diet, weight training. So here's an example of a woman in early perimenopause. You can see she's got these high estrogen surges, no ovulation, no progesterone. So look how high her estrogen is, how low her progesterone is. Here, you don't really have to focus in on this, but her testosterone is normal, her DHEA is low. And when we look at her, how she's metabolizing her estrogen, we can see that, let's see, her estrogens are high overall. So, of course, her metabolites are going to be high also. But when you look at how she's metabolizing her estrogen in phase 1, it looks really good. Like she's pushing most of her estrogen down that 2-OH pathway. And she's not pushing too much down the 4-OH pathway, not too much down the 16-OH pathway, which is great. Remember, the 4-OH pathway is associated with breast cancer risk. And the 16-OH pathway, it's more proliferative. It can worsen heavy bleeding. It's also associated with breast cancer. And in phase 2, she's methylating well. So she's clearing out her 2-OH and her 4-OH really well. I usually like to see this at 50% or higher. And her cortisol looks pretty normal overall. It is getting a little high at night, at bedtime. So whenever I see that, I kind of check in on sleep. And I ask, what do you do before you go to bed? Is that when you get everything done for the day? This metabolized cortisol is low. So it just tells me overall she's making a lower amount of cortisol. So I might want to work on supporting the adrenals. And one thing about low DHEA, remember, low DHEA is associated with more severe menopausal transition symptoms. Because DHEA, like when we hit menopause, our estrogens, most of our estrogen comes from DHEA. So if we don't have much DHEA to begin with, we're going to have low estrogen. So to reduce high estrogens in perimenopause, sometimes women will use DIM. You probably have all heard of DIM. It basically helps take estrogen out of circulation and push it mostly down that 2-OH pathway. So DIM is one option if you want to lower estrogen. The typical dosing is 50 to 500 milligrams a day. Just remember to make sure methylation is working well. And of course, if women take DIM, if they keep taking DIM month after month, but then they start entering late perimenopause, they might lower their estrogen too much. So watch out for these low estrogen symptoms. But there's other ways to promote optimal estrogen detox. Like you can get those cruciferous vegetables in your diet on a daily basis. We can do other things to help with regular bowel movements. You can consider stool testing. Fiber is great. Fiber is great to bind and remove estrogens. And then think about those phytoestrogens. Phytoestrogens are like adaptogens for the estrogen receptor. So if estrogen's too high, it helps lower estrogen activity. And if estrogen levels are too low, it helps increase estrogen activity. And with her organic acids, her indican was high. So this starts to make me think like, okay, maybe I'll do a stool test. Maybe I'll look at beta glucuronidase. Maybe the gut is a reason why her estrogen is so high. Maybe she's not eliminating it properly in the stool. So, she had high FSH, high estrogen production, low progesterone, and low DHEA. We might want to do adrenal support. We might want to add on adaptogens. We might add on DHEA. And we might think about stool testing. So for her, we gave her progesterone. We gave her oral progesterone to take every night. We gave her the broccoli extract, the sulforaphane, just to improve phase 1 estrogen detox. this helps, broccoli extract helps support glutathione pathways, which can be protective for that DNA. Like, even though she wasn't pushing too much down that 4-OH pathway relative to 2-OH, because she has such high estrogen, she's going to have high phase 1 metabolites and overall high 4-OH. So we can still do things to protect the DNA like NAC or glutathione or broccoli, because that's how 4-OH increases breast cancer risk. It causes DNA damage. Sometimes we'll give DIM for occasional use when she doesn't have hot flashes, when she doesn't have symptoms of low estrogen. Increase fiber to really help her detox that estrogen. We might give beta-glucuronidase to help lower estrogen levels. And then maca, this is the adaptogen we chose to help support her adrenals in perimenopause. Maca can be really helpful for like low androgens, for low libido. And after 3 months, she improved sleep and mild improvement in moodiness. So we kept her OMP at 200, but she was starting to have low estrogen symptoms. So we started to think, okay, we might stop the DIM, we might add on estrogen therapy. Okay, so with the late menopausal transition, remember we're getting close to menopause. And this is when that interval of amenorrhea is more than 60 days. So we're going months and months without a period. And we're more likely to have those low estrogen symptoms, like the hot flashes, the vaginal dryness. We talked about this already, how FSH increases, but AMH, inhibin B, and AFC continue to decline. And we might still have a period here or there. We might still have an estrogen surge here or there, but mostly our hormone levels are lower. So here's a 45-year-old woman. She's actually in her late stage. She's going 3 months, 2 months without a period. But on this cycle mapping, we caught one estrogen surge. She's got chronic bleeding, trouble staying asleep, hair loss. So for the majority of the time, her hormones are low. Her estrogen, her progesterone is low. But we just happened to catch 2 weeks where her estrogen surged. This woman, she had a uterine ablation, so we actually don't know how long her cycles are. But you can see overall that she's 49. She's like in that age range for late perimenopause. And we can see lower hormones overall. She's getting closer to menopause. And then, of course, after the final menstrual period, during that year before we're officially diagnosed as menopause, those low estrogen symptoms are just going to get worse. And FSH is going to get higher and higher. And then AMH, inhibin B, and AFC are going to be low. But of course, in that year, when your final menstrual period, before you've officially been diagnosed as menopause, your estrogen and your progesterone they're just going to be low. So estrogen therapy and perimenopause. Estrogen therapy in perimenopause or before those 12 months of no periods, it can offer substantial benefits for women. And, evidence suggests the risks of hot flashes, mood disorders, weight gain, and sleep changes might be related to irregular estrogen levels. You got prolonged levels of low estrogen, and then you'll get this high estrogen surge, for example, for a couple weeks or 2 or 3 weeks. So the use of perimenopausal estrogen therapy, it can reduce low estrogen symptoms by increasing that baseline estradiol. And it can help smooth out the ups and downs. So it kind of decreases that difference between the low estrogen times and the high estrogen times. And sometimes that can help with symptoms also. So here's the positive evidence for using both estrogen and progesterone during perimenopause. So there's evidence it can help with depression, can help with hot flashes, anxiety, sleep, can reduce metabolic disease, and reduce arterial aging markers, which is great. But we can support estrogen levels naturally with these things, which are really similar to how we were supporting progesterone. So here's a Dutch cycle mapping. She's in late menopausal stage. Like, look how low her estrogen is. It's just low. Like, she's getting close to menopause, so she's having a lot of night sweats, hot flashes, she can't sleep. A lot of these are just low hormone symptoms, right? And if you look here, her estrogen is in that purple band, which is the postmenopausal range. Her progesterone's in that purple band, which is the postmenopausal range. So her androgen production actually happens to be normal for her age, which is awesome. I don't typically see that. But look at how she's metabolizing her estrogen. Like, look how much red is in this pie chart. She's really pushing down that 4-OH pathway, which we don't want her to, right? This is that carcinogenic pathway. And her methylation activity is really low. So she's not clearing out the 4-OH or the 2-OH very well. So actually, one way you can decrease the amount of 4-OH is by improving methylation, because 4-OH gets cleared out in methylation. So this enzyme, CYP1B1, converts estrone to 4-OH. So if you want to lower 4-OH, you can avoid smoking, lower inflammation, avoid these polycyclic aromatic hydrocarbons, which are in like smoked foods. And with the 1A1, this is what takes estrone and pushes it down the protective pathway, the pathway we want estrogen to go down. So we might encourage this pathway with cruciferous vegetables, maybe not dim because she's got really low estrogen. We don't want to lower it more. Soy, fish oil, rosemary, flax seeds. I love flax seeds in perimenopausal women. And avoid high sugar diet and alcohol consumption. And of course, to support methylation, we might add on SAMe, magnesium, choline, B6, B12, folate, and betaine and TMG. So I love even adding on the choline and the betaine. You can get these in egg yolks, spinach, flax seeds. So with her cortisol, look at her cortisol is kind of on the higher end. And so her hot flashes, sometimes women have hot flashes from stress and high cortisol. So we're probably also going to work on lowering her cortisol to improve her hot flashes and to improve her sleep, right? We're going to try to use everything together. These are for you to look at later. They're basically ways to help, some ideas to help lower high cortisol, and then sleep hygiene and circadian rhythm support. I think for perimenopausal women, the sleep hygiene, the circadian rhythm support becomes even more important because falling asleep can be really difficult. And then with her organic acids, her B12, B6 markers are above range, which means she's deficient. And these are important for methylation. So we're probably going to give her B12 and B6 to support her methylation. And then her glutathione is high. And remember, pyroglutamate is high, which means her glutathione is deficient. And remember, we need glutathione to protect that DNA from the 4-OH. So we might want to give her glutathione. So we put her on an estrogen patch with oral progesterone. We gave her NAC because of that high 4-OH and that low glutathione. And we said, eat lower sugar, minimize alcohol. Let's get more cruciferous vegetables, flax seeds. Let's drink rosemary tea every morning. Remember, that's going to help support that 2-OH pathway, the protective 2-OH pathway. Let's get healthy fish in our diet, some non-GMO organic soy. And then we're going to add on some methylation support here. And have her do some gratitude journaling and sauna. So at follow-up, we started her at, what do we start at? A 0.05 patch. That's a moderate dose. And if you take the Intro to Menopausal HRT course, the Dutch course, you'll learn all about the dosing. And younger women often benefit from relatively higher doses. So if she says, my hot flash has only improved a little, we might bump her up to 0.75 or a zero point 0.1 patch. You know, if I have a woman in her early 40s,
Uh-oh.
I think we talked
What's
mostly
the
about this.
audio is cutting out here.
Oh, can you hear me now? Is that better?
Yeah, I think maybe the connection was a little lost, so but it sounds like you're back again.
Well, basically, the last few slides are things that you can print out. So, like treatment considerations, this is for vaginal dryness. These are non-hormonal options. Vitamin E is pretty popular for vaginal suppositories, hyaluronic acid. You can get cocoa butter. You can get these in like off, they come in little suppositories like over the counter. Herbal sleep support. A lot of these we know about. One thing that's cool is valerian has also been shown to improve hot flashes. Same with hops. So if they can't sleep and they have hot flashes, you might think about valerian and hops. And here you go. See hot flash support. You see valerian on this list. But a lot of these, St. John's wort might also support depression. So sometimes you can pair these depending on what the symptoms are. Like if they can't sleep and they have hot flashes, maybe valerian. If they're depressed and they can't sleep and they have hot flashes, maybe some St. John's wort. And this is something to print out later that goes into the perimenopausal dosing for progesterone, estrogen, and DHEA. All right, those are the references. I definitely want to say that, look at these slides and print them out to get a little bit more ideas of things that you can do during during the perimenopause transition. But overall, like with your patients, know that you can start hormone therapy before they hit menopause. And if you can't prescribe hormone therapy, you can always like still educate them on it and have them talk to their provider about it. Because for some women, it's really helpful. But we have a lot of other things in our pocket to help women during this stage. And if they're in early perimenopause and they have symptoms of high estrogen and estrogen dominance, we might think more like that DIM and good fiber and good hydration and working on gut health and overall estrogen detox. When they get closer to menopause, they tend to have just mostly consistent low estrogen symptoms. We might add on estrogen therapy, or we might use our phytoestrogens, progesterone. So, I mean, there's a lot of different options that we can do. And if you want to learn more, yes, we have a menopause management course, which is awesome.
Super. Thank you. That was a very nice presentation. And of course, lots of questions came up, and I'm just going to pull out some of them. So one is that I think is very relevant to bring up, like when do you collect when you have a woman whose cycles are like irregular? I know you can use the ovulation kit, but if they don't ovulate, and like so, if you can just fill us in a little bit on this, and
Yeah. Yeah. And this is when the cycle mapping can be helpful. If they're very irregular, you don't know when they're ovulating or if they're ovulating, they can collect like a cycle mapping just to look at their estrogen and the progesterone during that month. But if you're trying to time like a 1 day urine test or a serum test, it gets tricky. And it gets even trickier because the ovulation predictor kits with those LH urine strips, as we know, as we saw during perimenopause, the brain starts screaming at the ovaries and LH. So you can get LH surges that don't necessarily mean you ovulate. So sometimes in perimenopause, when women are using the ovulation predictor kits, they'll say, "Oh, I got a positive," but it's not actually because they ovulated. So if they're able to, I like to add in basal body temperature. So if they see a rise in their basal body temperature for 3 days, then they know that they ovulated 3 days prior and they can take their test like 2 to 4 days later, after that point. Because we want women to collect 5 to 7 days after they ovulate. But it does get very tricky. And for some women, we just say try their best. You can give them multiple Dutch kits and they can collect them a few days apart. There's something called the freezer trick where they dry their samples completely, put them in the freezer, and then wait until they get their period. So they can try basal body temperature, they can try ovulation predictor kit, they can try looking at their cervical mucus and looking at their body signals. But yeah, it can be really difficult. And sometimes women will just collect on any day, send the kit in, and at least you only need to collect in your mid luteal phase to look at the balance of estrogen and progesterone. Like you can still get a lot of data about estrogen and progesterone and androgens and cortisol and organic acids.
Yeah, and the whole metabolite pattern and
Yep, how they're metabolizing their estrogen, their androgens, exactly.
yeah. So rather just try and hit the right day rather than not testing. At least you will get some information. You kind of need to like dive in there and get some information as
Yeah,
well.
exactly. You can still get a lot of information.
So I took note of you saying early in the presentation how oral estradiol help on the lipid profile. And I see a lot of women like having high cholesterol levels,
Hmm.
some reason suddenly in their life. And then so could you say a little bit on this?
Yeah, oral estrogen has been shown to help lower cholesterol, like lower LDL and increase HDL. But if someone has considerable cardiovascular disease, of course, we can't use oral estrogen, so we'd have to use a transdermal estrogen. Or if they had, if their cardiovascular disease was significant enough, the recommendation is to not use estrogen. But yeah, in mostly relatively healthy women who maybe their cholesterol is a little high, sometimes oral estrogen can help. But transdermal estrogen may help also. So usually I'm more inclined to give the transdermal estrogen even if they have higher cholesterol.
Super. So, and then of course there was lots of questions as to like different patterns that has been seen, like normal high estrogen, but very, very high progesterone and all these, like what could the reason be and what could it be related to? But I think you've pointed out how challenging this whole thing is, and you kind of need to look at the whole pathway in order to understand the patient and look at the stress hormones and address that as well. So, and we have run over time as well. So I think I'm going to thank you very much for your time, and thank you everyone out there for your time. We will share the recording, we will share the slides, and I will share a link to the introduction of the Dutch course and the course that Dutch has produced on HRT to you all as well. And it's a link, and you just need to ask if you can get access to the document, and then I will give you access to, and that's like a webinar recording and with slides and everything as well. So you look out for the email that we're sending out to you, because it will be packed with lots of details. And yeah, also just reach out to us if you have any questions, and also if you have specific questions also in regards to this, like the collection, if it's a little bit difficult to find the exact timing. So, but otherwise, Dr. Ruef, thank you very much for your presentation. It was really nice and informative and very clinical and hands-on. Just
Yeah,
what
thanks for having me. And yeah, if you have any questions at all, please email, this one, info@dutchtest.com will get to me, or Dr. Ruef, DRRUEF at dutchtest.com. If you have any questions about this, you want to talk about it more, or dive in, I'm here.
Thank you. Take care out there. Bye.
Bye.
If you do not already have an account with us, please contact our team and we will assist you. If you found this webinar helpful, please like and subscribe to our channel.